Welcome to Knovva Academy. My name is Alex Crosser and I'm head of online learning. We're very excited to present the Pandemics and Public Health Initiative designed to help teens around the world be better informed about one of the most impactful events of the modern era. The COVID-19 pandemic is an unprecedented challenge to our modern systems of healthcare, but pandemics have threatened public health throughout history. What is a pandemic? How does it spread? And what lessons have we learned from the past that we can apply today? To help us answer these questions, along with some questions submitted by our students from around the world, we're very fortunate to be joined today by Dr. Don Goldmann, a professor of immunology, infectious diseases, and epidemiology at the Harvard T.H. Chan School of Public Health. Don, in a few words, could you introduce yourself to our students and describe a little bit of your background as it relates to our conversation today?
Sure. I'm actually a history major in college, but when I became a physician, it was pretty clear to me I was much more interested in infectious diseases and epidemiology than I was in sitting in the basement of some library studying ancient texts and getting musty and half blind. So for me, getting out and actually dealing with epidemics and trying to help people that way was much more appealing. And importantly, I did spend 2 years as what's called an epidemic intelligence service officer, fancy title for somebody that works at the Centers for Disease Control and Prevention at the United States and goes out and tries to solve epidemics.
So I guess we should probably start at the beginning. And I've been reading a lot of articles about coronavirus and COVID-19. And they're all very careful to say a novel, or the novel coronavirus, a new coronavirus. Can you describe what is a novel virus and what makes it so dangerous?
Well, they're two separate questions. So I'll talk about why people say it's novel. First of all, everybody listening to this call, I promise you, has had more than one coronavirus infection already. And that's because it's one of the most common causes of a cold. So I get colds 2-3 times a year, and I'm promising you that even though I don't go to a virology lab to have it worked up, that at least one of them is due to coronavirus. So coronaviruses are circulating all the time. We know a whole lot about how they cause infection. So COVID-19 is novel because it is a very contagious virus. It's become a pandemic, which means it's spread globally. I know there were lots of arguments at WHO and vilification of WHO for not declaring it a pandemic earlier. It's a technical definition of how widely spread it is in the world. It's a pandemic, but its novelties, it's very contagious, and it's probably more lethal. What is more lethal than, let's say, influenza, but not as lethal as SARS, which had a very high mortality rate. It's extremely bad organism to acquire. So these are novel. They're genetically distinct.
So what makes it so contagious, or what causes a virus to become a pandemic?
Yeah, so it has to be contagious, and you've asked the right question. We actually don't know exactly how many viral particles you need to cause an infection, but it doesn't seem like it's a great number. So there are multiple instances where people have had parties or dinners or meetings, and half the people or so have become infected. So it's clearly very contagious. And one of the reasons that it's problematic is that you're contagious before you have the symptoms of a cough or other fever or whatever, so that you can be unsuspectingly spreading the infection to your neighbor before you're even sick. And some people never get sick. They just don't have symptoms at all, and yet they're contagious. The virus reaches very high levels in the nasopharynx, the area between the nose and the throat. And every time you cough or you sneeze, or if you talk forcefully like I'm doing now, if I say a letter P, if you looked at my screen here, you'd probably see little flecks from the droplets that I'm generating. So very contagious. And of course, these days, the transmission globally is far easier than it was before we had international trade and air travel and so forth. The virus itself probably is a bat virus. It's interesting, bats seem to be the species that harbors a lot of viruses that eventually get to man. And it's a complicated picture, but the bats don't get sick and they live in a kind of balance with these viruses. And the bat can either infect man directly or it can infect an intermediate host, like with SARS, with the civet cat that was sold in markets in parts of China. So that's where the virus comes from. It has to adapt itself to be both pathogenic to cause disease in humans and the spread from human to human. A lot of viruses don't do that well. So bird flu, we've heard a lot about bird flu, these very dangerous influenza strains. In general, they've not been able to adapt themselves well to both infect humans and then to have humans infect other humans. Most of those cases have been people who take care of poultry, for example, and are directly exposed to the birds that have the flu. So the virus has to adapt to humans to cause disease, has to adapt to humans to spread from human to human, and then it has to be highly infectious, and its spread is enabled by air travel and international commerce.
So I got a number of follow-up questions to that. So I guess the one that encompasses it all is, what questions are we still trying to answer about COVID-19 or about SARS-CoV-2?
Well, we are still trying to figure out exactly how it causes disease, but I think we're getting there already. We know what cells it invades. We know that unlike other viruses of its type, it replicates really quickly, and the highest number or titer concentration of viruses very early in the disease, in fact, before symptoms in some people. We also know that having reached that high peak, it lingers for probably 14 days or longer in people who've been infected. And that makes it hard to know when you can release them to the community. So, you said, I think that you knew somebody who has this virus, and the question is going to be, well, when is she going to be comfortable? When are you going to be comfortable letting her out of her self-imposed quarantine? So we're still learning about that. We're learning more about the impact in children. Children don't seem to get sick, but the reason we close the schools is that we know that although they're not really seriously ill usually, they still can be infected with low-grade symptoms and then spread amongst themselves, and then they come home and infect grandma. So that's an area that we're trying to learn more about. Ultimately, we want to understand what there is about the virus that can serve as a target for treatment and for the development of vaccines. And I can tell you one thing about the virus we've discovered already. It's amazing how quickly we learn in science these days. When I was young, what we're doing now wouldn't have been done in years, let alone in weeks. I mean, within weeks, we had the sequence of the virus. We were able to take that sequence of the genetic material and begin to think about vaccines. We knew that it had a special protein called a spike protein that sticks out of the coronavirus. And we know it attaches to something called an ACE2 inhibitor on the cells of the respiratory tract. And we know how it invades. I mean, it's amazing what we know about this virus already. But that doesn't mean we can easily translate that into diagnostic tests, vaccines, and drug treatments.
So before we get to vaccines and treatments, I do want to spend a little bit more time on testing, because that does seem to be a key factor in what will help us return to some sense of normal. I've seen headlines in the past couple of days that one of the main rapid tests may be producing as high as 15% false negatives. To actually ask the question, I'm going to turn to Betty Bao from Xiamen University in China.
Hello everyone, my name is Bao Zhuofan, but you can also call me Betty. I'm from China. I'm currently studying German in Xiamen University as a sophomore. Due to the inaccuracy of the present ways of testing, is there clinically a better way of testing COVID-19 and identify those patients, especially those without symptoms? That will be all. Thank you.
Well, thank you, Betty, and it's a great pleasure to speak to somebody from China. I had the great pleasure of visiting 5 cities in China not too many years ago to give talks at universities there. So it's great to have your question. So diagnostic testing is really going to be critical here, especially testing for the virus itself, which is I think what you're asking about, but also for immunity or antibody to the virus. So let's talk first about testing for the virus. The main way this is done is through polymerase chain reaction type testing that actually detect the genetic material of the virus, the RNA, the ribonucleic acid. And the gold standard, the best test right now that we have is a nasopharyngeal swab test. So go up through your nose and down your throat, and it's very uncomfortable. Also produces a lot of aerosols of virus because people cough right in your face and you have to be properly protected with a face shield and a mask. But that's what gets the most accurate results. It's the most sensitive test in that you don't have false negatives. That said, even that test has problems. If the sample isn't taken correctly by the person taking it, then your chance of finding the virus are diminished. If the person is either very early, very, very early, or very late in the infection, the concentration of virus in the nasopharynx is lower and the test may miss it. That's why you hear some people who are negative by test and then they turn positive. Well, are they reinfected? Probably not. They probably have low levels of virus that was just missed by the test when it was done, and now the test is picking it up. The easier you make this test for rapid use by healthcare people or for self-administration at home, the more you tend to sacrifice the sensitivity of that test as a screening test. When you have a screening test, you want to find out, is somebody infectious or not? You don't want to have falsely negative tests. That's a disaster. We're already seeing that one of the very popular rapid tests may not be as sensitive as we hoped it would be, that there are false negatives. We now have a home kit that you can take the test yourself, but it's not this nasopharyngeal awkward test. It's done through the mouth, and I will see how sensitive that is. It's not going to be as good as the more formal tests that I mentioned. So there are trade-offs, but I can tell you one thing: if we don't get better testing and approach what, let's say, South Korea has done, which is quite amazing, at least in the United States, we're not going to get back to normal anytime soon.
So let's put aside false negatives for a second. If someone still has the virus in them or is recovering, is a low enough level that they test negative, is there a risk that they're still contagious?
Yeah, so that's a good question. Under the right circumstances, probably. So, let's just say that I blow my nose because I sneeze because I still have some residual symptoms, even though I'm really better. I mean, when you have pneumonia, you're going to cough for weeks, right? And so I cough into my hand because I'm sloppy. I don't do it this way. And even if I do it this way, my sweater's all snotty. So,
but you're a professor of immunology.
Yeah, it doesn't matter. You know, I was on just so the students know, I was on a call and the guy on the other end coughed in his hand and I was going to say something, but I said, I don't want to embarrass him. And then 5 minutes later, I coughed into my hand. So these are habits that are hard to break. But if I did that and then I shook hands with you and you touch your eyes or your nose, even if I have low titer of virus, low concentration, I think that that's a threat. Obviously, the fewer viruses you have in your spit, then the lower the risk. So
one of the most important steps that I've been hearing about in terms of prevention and return to normalcy is the development of a vaccine. So I was wondering if you can tell us a little bit about vaccines and what it takes to develop them.
Yeah. So everybody listening, wherever you are, have probably been immunized against certain organisms, viruses and bacteria. You almost certainly had a immunization against mumps, rubella, and measles. You probably have been immunized against whooping cough. You've been immunized against polio, most likely, and diphtheria, and various bacteria like pneumococcus and so forth. So You've all had vaccines, and the reason you get them is that they produce antibodies reliably because they're good vaccines and protect you against disease for some or most of your lifetime. So the goal here is to create a vaccine that we can use to protect against SARS-CoV-2, the COVID-19 virus. There are at least 20 or more vaccines under development in the world now. One of the most important things we need to foster is collaboration. I mean, every time I see a leader in the United States trashing some other country or saying things about another country, I'm saying, well, what if they're the country that invents the vaccine that will save our skin, right? So I know that this organization where I'm talking for today is all about collaboration. Well, this is where world collaboration is absolutely imperative because I don't know who the winner is going to be. The United States main vaccine candidate is actually a platform for making vaccines that's never been used to make an approved vaccine. They're basically taking RNA, messenger RNA, that they hope will target through nanoparticles the immune cells in my body, and then I'll generate the right antibody to fight the virus. Well, that's never been incorporated in an approved vaccine as far as I know. So the nice thing about it is it's easy to scale. Once you get that down, you can make millions of doses relatively easy. That's why they're doing it. Other people are just going to be trying to isolate that spike protein and fashioning it into some sort of vaccine that will produce antibody. To do that, you've got to usually add something called an adjuvant. That makes sense, adjuvant, that will boost the immune response. But that's another step. So all these companies and governments have different approaches. Once somebody actually gets a vaccine that, let's say, works in the laboratory and then works in some animal, then we got to safety test it in humans, and that's what's starting now. It's called phase 1 trials. The whole point of that is to come up with some notion of whether that vaccine is safe. This is not trivial. Some vaccines in history have not been safe. So people are very worried about dengue fever vaccine. If you're familiar with dengue, if you live in the Caribbean or in Asia, you're familiar with dengue. That vaccine actually paradoxically produces antibodies that are enhancing for the disease. And I'm not going to go into why that is. It's the wrong antibodies produced to that vaccine. And it's now very controversial and dangerous, actually, to use some of those older vaccines. So we don't want to make that mistake now. If we're going to rapidly immunize, let's say 300 million people in the United States or a billion people in wherever you live, we can't afford that vaccine to be 95% safe and have 5% of the population with severe sequelae. So getting past that phase 1 is a big hurdle. And then you've got to do clinical trials to show that it actually works. The most massive clinical trial I'm aware of was with polio vaccine, the Salk vaccine, which you probably all had. We immunized hundreds of thousands of school children in the United States to determine whether that vaccine was better than no vaccine at all. And you can look it up on the internet. It's absolutely fascinating. And within less than a year, once we had the vaccine, we determined that that vaccine worked. Well, that's great. Then you have to scale it up so that you can have it for the whole world. And that's a huge manufacturing challenge. In fact, with the polio vaccine, and God willing, this will not happen again, one of the companies did not inactivate the polio virus sufficiently. And there were thousands of cases of paralytic polio produced by the vaccine that was manufactured without good quality control. We're better off today, but you can imagine in the haste to get everybody immunized to protect Don Goldman and his elderly ilk from COVID-19, there could be some shortcuts, and shortcuts will kill people.
To follow up on that, I do want to turn over to another student question.
Hi, my name is Manal Dembry and I'm from Revere, Massachusetts. How accessible do you think COVID-19 vaccines will be to the general public?
Yeah, how accessible will they be? Well, I've already talked about the problems of scaling up the production. Then the question is, how do you get them in people all over the world? And I got to make a little side comment here. You know, equity and social justice are really, really important. When I was on a call with the NIH here in the United States, I asked what's going to happen in Africa. are they going to get the vaccine? Are people living in Sierra Leone going to get the vaccine? Are people in the United States living in the inner city of Detroit going to get the vaccine? How are they going to get to the place where the vaccine's given? I mean, there are enormous global disparities and local disparities in access to care and who gets what. So that's the main point I want to make. It's going to be logistically difficult in an equitable system to get to everybody. It's going to be logistically very difficult to get everybody in an inequitable system. So depending on where you live and what your health system is like, and how much they consider social justice a priority, that'll depend on whether everybody who deserves the vaccine actually gets it.
Thank you for touching on such an important topic. So how long should we expect COVID-19 to be with us? We just discussed what it would take for a full recovery, but what do you think a realistic goal is in the next couple of years?
Yeah, so there's one school of thought, which I think is correct, that it will become part of our repertoire of viruses that circulate in the community and wax and wane and carry a certain level of severe infection and mortality. Maybe it'll become sort of like influenza that we live with, and we understand that some people are going to die, and the season will come and it will sweep through, and then it will abate somewhat. So it just could become part of the fabric of the viruses we live with and worry about, but perhaps a little bit more severe than others. A vaccine would fundamentally change that, right? It would get us to a point where if people get vaccinated, they're going to be protected. But short of that, at least until we have a vaccine for the next 12 or 18 or 24 months, we can anticipate waves of infection. I mean, we can loosen up and get back to something like semblance of normal. But if the virus is still there, which I think it will be, it'll continue to break out. The way to deal with that is to have a dual mindset. First, if the level of disease gets to a certain lower level, then you can actually, if you have good testing, identify people who are infected, isolate them, do contact tracing, and contain. We've gone beyond that down in the United States for the current time because we don't have that level of testing. There are too many infected patients, but we could get back to that level. So that's one mindset, is this is going to happen and we're going to just jump all over it and prevent it from becoming a big deal. Secondly, you have to say, well, what is the tolerable level of background disease? As I was just saying, we live with risk all the time. I'm at risk every time I drive a car. I'm at risk even if I get flu vaccine because it's not perfect. What can society accept as a reasonable level of risk and get back to something resembling normality? Absolute safety, which is what a lot of American people seem to think they're entitled to, is impossible. And I don't like it when people say, well, your chances of dying in a car accident are just as great as dying. Well, that's not relevant because car accidents are not an infectious disease. And so it's a bad analogy. But the fact is we live with all kinds of risks. Every time I walk out of this place, like I'm deciding whether I want to buy rabbit fencing to protect my vegetables I'm trying to grow so I can self-sustain myself through this crisis. In order to get that rabbit fencing, I probably am going to have to go into the place that sells it because they don't seem willing to deliver the rabbit fencing. I'm going to make a calculated decision. How much risk am I willing as an individual to take? And society will have to calibrate what risk as society are we willing to tolerate, what degree of illness and death is tolerable, if not desirable.
All right, well, thank you for being straight with us. I think it's important for us to have a realistic understanding of what our future may look like. Hope is vital and keeps us going, but understanding exactly the challenges that we're going to have to navigate are really helpful. So Don, I really want to thank you so much for taking the time to share your expertise with us today. It's been fascinating and very informative. And so before we sign off, I just wanted to know if you have any additional things you'd like to share with our student community, any parting thoughts or words of wisdom.
Because this is a learning opportunity for everybody here. We're all going to be smarter because of it. We're going to talk about things we normally wouldn't talk about in a way that's realistic. And the people who were motivated to tune into this particular broadcast are very likely to be people who make a difference in the future. So it's you know that when you invited me, it didn't take me but 30 seconds to agree, and that's because it's truly a honor.
Thank you very much. Best of luck, staying safe to you and your family, and I hope we have the opportunity to speak again soon.
Well, I wish you had a cure for my rabbit infestation, but I don't guess that's going to happen.
All right, I'll get working on it. I'll let you know. Thank you. Bye.